Good evening, everyone. Thank you so much for joining us tonight. Please give us a few seconds to let everyone gather in, and then we'll get kicked off. Alrighty. Good evening, everyone. Thank you for spending your time with us as we dive into this important discussion around prostate cancer survivorship. September is Prostate Cancer Awareness Month, and we want to take advantage of this opportunity to discuss prostate cancer therapy and some of the most common side effects that sometimes occur after a man goes through particular treatments. So thank you for spending the next 45 minutes of your time to join us in this educational webinar and for prioritizing your own health. Just a few reminders. This presentation is completely anonymous. You aren't on camera and no one can see your name. We do this because we hope to have an interactive discussion and we want you to ask questions even if you think they're too embarrassing or you don't know the right words to say. So to maintain privacy, you can write your questions in our anonymous chat box at the lower portion of the screen. We'll save time at the end of the presentation to answer any questions you may have. We have over 30 people in attendance so far. So remember, if you have a question, somebody else probably has the same exact question, so please don't be shy to ask. Our speaker tonight is Dr. Michael Kemper, who is a fellowship-trained urologist and a men's health expert at Georgia Urology. Dr. Kemper focuses his practice around helping men who are dealing with men's health issues, like many of the men joining tonight's webinar. He's a wealth of knowledge and information to share this evening. Thank you, Dr. Kemper, for joining us this evening. If you're ready, I'll turn it over to you.
Thank you so much for that introduction, Lee. And thank you all so much for joining me today to talk about men's health and specifically for prostate cancer recovery. As she mentioned, September is is Prostate Cancer Awareness Month. And, prostate cancer extends beyond just curing prostate cancer. There's also effects that come with treatment that we need to address and deal with as urologists and as men. My name is Dr. Michael Kemper. I am a physician, a urologist with Georgia Urology. I see patients in our Decatur and Conyers offices. I went to University of Michigan, did a residency in Medical College of Georgia, and then a fellowship in sexual medicine and men's health at Nova Southeastern University in Miami afterwards. So prostate cancer is the most common non-skin cancer in America. It affects nearly 1 in 9 men. It's one of the most common cancers that affects men. It is over nearly 3 million men in the U.S. count themselves as prostate cancer survivors. And there are many side effects of treatment. Common ones for men, especially after a prostatectomy, are bladder leakage and erectile dysfunction. So prostate cancer has 3 main treatment options. There is active surveillance. So active surveillance is watching prostate cancer and monitoring it. That's appropriate for people who have low-risk prostate cancer. People with higher risk disease, though, typically require active treatment, of which there are 2 main options: surgery to remove the prostate, or radiation to radiate the prostate and kill the cancer. These have their own benefits and risks. There is good evidence that both treatments work similarly well to cure prostate cancer, but they have different side effects and different long-term outcomes. The first portion of our talk is going to focus mainly on stress urinary incontinence following prostate cancer treatment, in particular following prostate cancer surgery. And both of ours tend to be more focused on prostate cancer surgery today, although there is some application to radiation treatment patients as well. So, stress urinary incontinence following prostate cancer treatment. So, there are approximately 70,000 radical prostatectomies performed each year. A radical prostatectomy is a surgery to remove the prostate. Typically, it's done robotically. The male urine control is through two different portions. There is an external sphincter, which is those pelvic floor muscles, the Kegel muscles that you ask to squeeze down to try to hold back the urine. And there's also an internal sphincter within the prostate that assists. When that prostate is removed, the urethra is sewn back to the bladder, but that internal sphincter is gone. And now that external sphincter, those pelvic floor muscles, have to work a lot harder than they ever have in any man's life. Almost every man leaks initially, and a year after treatment, about 85% of people are doing really well, have relatively minimal leakage. But that means that a substantial portion, 9 to 16%, of men will still have some persistent leakage of urine requiring pads. How common is it? 1 in 10, as we mentioned, up to 85%. If you have bladder leakage that's bothering you, you have options. This stress urinary incontinence can definitely affect the quality of life. And this is the thing, honestly, post-prostatectomy, for people that have this, this is the thing that most affects them. People tend to be more depressed. The pads can smell of urine. People feel socially isolated. They feel that they are not able to get out and about because of the leakage. It's normal immediately following radical prostatectomy to have some incontinence, and it continues to get better for the first year of recovery afterwards. Pelvic floor physical therapy, doing your Kegel exercises, these are things that can really help restore that continence. Not everybody can get there, though. And so for people that do have persistent issues with leakage after having their prostate removed, there are options for treating that. So bladder leakage after prostate cancer. So afterwards, you may have anywhere from a few drops of urine when you cough or sneeze or stand up to a full uncontrolled stream as soon as you stand up and no ability to hold your urine back at all. That tapers off within the next several weeks or months. Most people regain bladder control within a year. But if it persists, we've got stuff that we can do to fix it. So how do we restore continence? For mild leakage, many men will just wear absorbent pads. And by a year, a lot of guys are just working with a single pad for safety. Adult diapers may be necessary for people with more bothersome leakage. Or there are things like condom catheters, a clamp that can be used. In the initial healing period, Kegel exercises can help significantly with improving continence and restoring that function. For more moderate leakage, there are things like bulking agents, such as Bulkamid is the one that we use most often. That's more for mild leakage or post-sling, honestly. And then there's the male sling, which is intended to support the urethra, prevent those leaks when coughing, laughing, or sneezing, and can restore continence. For more severe leakage, or for men primarily that don't have any ability to control their stream at all, there's the artificial urinary sphincter. So a cuff that goes around the urethra and then always maintains that strength. Whenever you need to urinate, you pump the pump, it opens up the cuff, and it allows you to pee. And it automatically closes again. So this is an animation focused on the artificial urinary sphincter. Yep, it's playing. So there are 3 components. There is this pump that's in the scrotum. There is a cuff that's around the urethra. And then there's a pressure regulating balloon that's up in the belly. Whenever you need to pee, you pump the pump and it moves fluid out of the cuff and into the pressure regulating balloon. That then allows you to urinate. Over the next 90 seconds or so, that automatically fills back up and cuts your urine stream off to allow you to be continent. So what to expect after a sling? Outpatient procedure, small incisions, approximately 2 to 4. So it's an opening on the perineum underneath the scrotum. Takes me about 45 minutes. It's usually about 2 or 3 days before you're up walking around, mild to moderate pain. Usually wait 4 to 6 weeks to activate it for the artificial urinary sphincter, sorry. So 95% of patients are satisfied with it. 90% are satisfied with continence long-term. 90% would have it again. So people with severe urinary incontinence, this is by far our best option. Typically, we can mostly get it covered, Medicare or private insurance. The other option is the male sling as well, which is my go-to for people that have mild to moderate incontinence. So side effects of the sling include persistent leakage, retention of urine in rare circumstances. The artificial urinary sphincter, there's more moving parts. It usually lasts 10 to 15 years, but may require revision surgery at some point in the future. So incontinence after prostate cancer treatment can be effectively managed. If it lasts more than a year, permanent solutions can restore your urinary control. The sling or the artificial urinary sphincter could both offer a long-term solution. Restoring sexual health. So the other big thing, and this is true for both radiation patients and prostate cancer surgery patients, is erectile dysfunction. So the nerves that go to the penis go right over the top of the prostate. And so during surgery or radiation, they can be within the treatment field. In addition, the arteries and veins that feed the penis also can be affected. And people with after prostate cancer treatment tend to have more venous and arterial disease to the penis, leading to erectile dysfunction. Overall, erectile dysfunction affects 25 to 75% of men, up to 50% of men after radiation, and up to 50% as well 1 year after a robot-assisted radical prostatectomy. That is something that can get better, but it typically can take up to 2 years to see the full recovery after surgery for prostate cancer. And even then, everybody takes a hit to some degree. So that may mean that if they're perfect beforehand, people just need some pills. If there are issues and the pills don't work, or they're already eating pills, they may need injections, a vacuum device, or even a penile implant. So it can take, as we mentioned, might take as much as 2 years or longer to regain sexual function. Penile rehab, so that's using a vacuum device typically, can help to restore that flow. But if it doesn't recover, we've got treatment options available. So there are oral medications, the pills, Viagra or Cialis. There's vacuum pumps. These can frequently be used for rehab in that initial healing period, and also can be used to have sex, although many people have mixed results. There's also penile injections. There's urethral suppositories, or there's the penile implant. So penile implant. Penile implant's an inflatable device that uses a pump placed in the scrotum to inflate and deflate the device. It's 3 parts: a balloon that's up in the belly, a pump that goes in the scrotum, and then 2 cylinders that go in the penis. Whenever you want to have sex, you pump the pump, it gives you an erection. Erection lasts as long as you want. Whenever you're done, you press a button on the pump, squeeze the penis, the erection goes away. The benefit for this is that it does restore a lot of that spontaneity. So you don't have to worry if the pills are going to work, or if you took them 2 hours ahead of time. You don't have to worry if your injection's getting out of the freezer, if it's a little bit too old. You don't have to worry about the ring blocking things off after you use the vacuum pump. This just, you go to it and it works. It's all completely concealed inside the body, and it lasts for as long as you'd like. So this is an animation to demonstrate the device. So on the penile implant, there is a pump that goes inside the scrotum. Whenever you want to have sex, you pump that pump. It moves fluid from the balloon that's up in the belly into the cylinders that are in the penis and gives you an erection. Whenever you're done having sex, you press a button that's on the top of the pump, and that takes lets fluid out of the balloon, and the erection goes away. It's usually an outpatient procedure under anesthesia. People go home the same day. I operate primarily at Emory Decatur. You make a small opening on the scrotum. Takes about 2 to 4 days of pain, bruising, swelling, up to 2 weeks, more or less. 4 to 6 weeks after surgery, most people are able to start using the device. Typically can be covered by most commercial insurances, and Medicare does cover the device, although every insurance is different, unfortunately. If you have private insurance, high deductible, we can frequently work that out. Surgical procedure does have risks associated with it. It's a mechanical device, usually lasts between 10 and 15 years. People lose some length just from having erectile dysfunction. And so this is intended to restore function It's not going to make it 25 again, but it is going to make it so that this works reliably every time that you want to have sex. So ED, common problem to be associated with other conditions, primarily prostate cancer treatment in this case, a variety of treatment options. And penile implants are one such option. In a lot of guys who've had a prostatectomy where the pills aren't working, the injections are uncomfortable or don't work well enough, and the pump just really doesn't work well enough, a penile implant is an awesome solution. So assess your condition, sexual dysfunction. Look at how the ED assessment. You can go to edcure.org and go online, and they will have a lot of information about ED, as well as finding folks that can treat that, including myself. There's also incontinence. You can look online for that. Look at the bladder leakage quiz. You can monitor your pad usage, and then look at fixincontinence.com, which has a lot of information about those solutions as well. So if you do want to see me, and you're about to have an opportunity to have a lot of questions, but before that, so we do hold some slots for people that have been to this webinar. The easiest way to make an appointment with me is to scan that QR code that's on your screen right now. And that will take you directly to our webpage to make an appointment. We have some spots that will allow you to do that. But in the meantime, I am here as a resource for you guys. What questions can we go over?
Dr. Kemper, thank you so much for that presentation. I will kick us off with some questions.